So this is the voice PowerPoint for statistical measures of validity. So when we're talking about validity and measures, the easiest way to review these concepts, I think, is to think about diagnostic tests. So as you can see here on the slide, we're talking about throat cultures. So we're used to, as clinicians, thinking about the sensitivity and specificity of throat cultures or some kind of laboratory test. And that really helps us understand these concepts of validity in diagnostic tests. So remember that the sensitivity is the test's ability to obtain a true positive. So you do the throat culture on this young lady who has group A beta hemolytic strep, and that throat culture comes back positive. Specificity, on the other hand, is the test's ability to obtain a negative when what she has is maybe a viral infection in her throat or mono or something else causing it. So specificity is the test's ability to obtain a negative when the condition is absent. And we really want to compare our test results, our throat culture, with the gold standard or reference standard. And so this table is showing you an example of that. And a lot of the specificity and sensitivity of rapid tests, rapid throat cultures, have been done by various companies compared to the gold standards because they were not quite as good with the sensitivity and specificity. And you can see some of those early data there. So now when we're talking about validity in diagnostic tests and we're talking about this sensitivity and specificity, we have some formulas that we can use to actually calculate how these instruments shake out. So your reference standard is your true diagnosis, and that's like in the case of strep throat, it's usually compared to an actual plated specimen and whether or not that organism grows out on the culture. But what you want to do with the sensitivity is look at the formula A over A plus C. So if you look at our table here, and you think about at the top, we're talking about this child has the disease or this child does not have the disease. And these are the tests. So a positive test and a negative test. And so in block A, you have a positive test when the kid really has the disease. In block B, you have a positive test when the kid does not have the disease. So let's say the rapid strep test comes up that this is strep, but in reality, the child doesn't have strep, they have mono. That would be your false positive. And then down here in the negative row, we have a false negative. So the kid actually has strep, but the rapid strep says it's negative. And that happens fairly commonly with rapid strep. So that's why you always send a backup culture when you're getting throat cultures in kids and the rapid strep is negative. We're pretty sure the true positives are pretty, it's pretty sensitive, but the specificity is not as good. So we usually send a backup. And then D is your true negative. So the kid doesn't have the disease and the test comes up as negative. So all your positives are both your true positives and your false positives are A plus B. And your false negative and your true negative are C plus D. And that's how you come up with your sensitivity and specificity formulas. So let's just think about some of these concepts a little bit more. And again, it's a simple kind of 2x2 table that helps you look at these things: the true positives, the false negatives, and the true negatives. And then you can say a variety of things about the data when you have these comparisons with a gold standard. So you can talk about the diagnostic accuracy, and that would be A plus D over the total N. So that would be your true positives and your true negatives over the total N. And that's your diagnostic accuracy. Your false positive rate would be 1 minus the specificity. Your false negative rate would be 1 minus the sensitivity. The positive predictive value is A over A plus B. So remember, A is your true positives over your true positives and your false positives. And then your negative predictive value is D over C plus D. So remember, D is your true negatives, and it would be looking at all the negatives, C plus D. Your prevalence is A plus C over the N. So your true positives plus your false negatives over the N. And then your positive likelihood ratio would be the sensitivity over 1 minus the specificity. And your negative likelihood ratio would be 1 minus the sensitivity over the specificity. And these are just different ways that you can look at the data when you're trying to make sense of the diagnostic or screening tools that you may be using. So this figure talks more about when we're looking at prognosis for people with bowel cancer. So we know that 9 out of 10 people will survive 5 years or more when diagnosed with stage 1 bowel cancer. But we also know that fewer than 1 out of 10 people survive 5 years or more when diagnosed with stage 4 bowel cancer. So these are looking at those likelihood ratios. So the other thing to just keep in mind is the likelihood ratio tells us how much more likely it is that a person has the diagnosis after the test is done. It's a post-test probability, and it indicates the value of the test for increasing our certainty about a diagnosis. The likelihood ratio has an advantage over the sensitivity and specificity and the predictive value because it's independent of the prevalence of the disease. So those are just things to keep in mind. And our abbreviation then for the likelihood ratio is this label here, the LR positive. So that's a positive likelihood ratio, and this is a negative likelihood ratio. So some pretest probabilities that we can look at are generating a hypothesis about a likely diagnosis from the literature. So let's go back to our example of kids with strep throat. So we know from both, both our reading the data and clinical impression, we can formulate a hypothesis about whether or not we think this kid's going to be positive for strep. So we know that kids with strep are more likely to have a fever, and they're more likely to have enlarged lymph nodes, and they're more likely to look a little sicker. And then your clinical impression from your own practice, if you've been seeing a lot in your clinic, or in my practice, I was in a school-based clinic and we knew it was in the school. So that also would influence our clinical impression, and then just your past experience. So even before you see this child, you may have a suspicion about what you think might be going on based on those things. But again, using that strep throat as our example, we know that clinical impression alone, and reviewing the literature, there's a lot of variability in how kids present, and that there's not good positive predictive value from your clinical impression alone. So the diagnostic tests improve the conclusions, and that's your post-test probabilities. And that's where your likelihood ratio comes in to determine the post-test probability to improve your assessment of whether or not this condition is present in this patient. So another concept that we really want to talk about a little bit here is a way to kind of combine the balance between the sensitivity and the specificity. And one way we can balance these two is to examine the two together graphically, and that's called your receiver operating characteristics, or your ROC curves. So the way you do this is to actually determine some cut points and calculate sensitivity and specificity for the various cut points. And that area under the curve is the probability of your correct diagnosis. If the area under the curve is 0.76, the diagnosis will be correct 76% of the time. And as you construct that ROC curve, you know that you're going to plot these, you're going to set these cut points, and then you're going to plot your true positives on that y-axis and your false positives on the x, and that's your specificity. And then you'll get this nice curve that will help you determine the probability of your correct diagnosis. Another thing we want to mention here is the clinical prediction rules. And the clinical prediction rules are tools that can quantify the contributions of different variables to the diagnosis, or the prognosis, or even the likely response to treatment for individual patients. So this may include things like age or gender, or as we said with the bowel cancer, it could be stage at the time of diagnosis. So these add additional variables to your ability to predict something about the condition in the patient. So how do we approach this? There's a variety of steps here that I just want to walk you through. So if you're developing a clinical prediction rule pattern for a certain cohort of patients, you are going to come up with predictive factors that you identify in your study in this cohort of patients. And you're going to determine what the rules are and establish from your previous findings which variables are most predictive. So as I mentioned, is it age? Is it gender? Is it ethnicity, race? Is it stage of the disease at diagnosis? What are those variables? And then what are the rules? And then you're going to validate those rules on several different cohorts of patients in different settings so that you can determine, was this just from my previous study and it was just coincidental, or does this happen over and over and over, that we'll see that there's a certain age group that's at risk. Let's use the colon cancer example. We know that it's most likely to occur in people over 50. That's why we're suggesting colonoscopies then. And then validating the rules in several cohorts. So is that true for Hispanic populations and African American populations and Caucasian populations, or is that just true in my narrow population that I started with? So you want to validate the rules. And then the impact analysis is to assess if the rules changed clinical behavior and improved outcomes. So did you change people's screening based on this? Or did you change patient outcomes because you're doing better screening? So you want to look at what the impact is. So another thing we want to just touch on briefly here are the statistical approaches to measuring change. And there's a variety of different terms that you'll see when you're reading your articles and critiquing them. And I want you just to be clear on what the difference is. So minimum detectable difference is the ability to pick up a change. And it depends on the precision of the instrument and the standard error of the instrument. And it's really based on statistics. Your 90% is your Z of 1.65, and your 95% is your Z of 1.96 confidence intervals. And that just comes from the normal distribution, right? And those tails. And the minimal clinically important difference is, so there's these statistical differences, but in the real world, does that matter? And in the clinical world, is that a meaningful difference or not? And so that's your minimal clinically important difference. And that's why it's important to think of this not only from the mathematics statistical sense, but the kind of so what. And examples of this is how many people do you have to screen to pick up one case? And if it's really expensive screening and you are only going to pick up one case after thousands of screenings are done, then it's usually determined that that's not going to be clinically important difference, and maybe you can't warrant the expense. And the example that comes to mind for this is doing EKGs as routine screening for all kids for a sports physical has been one of those controversial things for a while because of the extra expense. And then there are some who say that you really actually have to do an echo to pick up some of the rare things that can cause a sudden cardiac death. And the prevalence of those is so small, and your echoes are not 100%, and they're expensive to read. And so that's just an example of when there may be minimal clinically important difference. And the expense is huge, so people might not suggest that kind of screening. And then the last thing that we need to talk about as we are talking about statistical approaches to validity are effect size. And effect size is generally considered to be more appropriate to determine if meaningful change has occurred because it takes into consideration the group variability and is a little bit more helpful when we're trying to determine this minimal clinically important difference. So, so there's 3 different approaches to getting an effect size, and there's standard measures of change from baseline to final measurement. The first one is the effect size index, which is a ratio of the mean change score divided by the standard deviation of the baseline scores. Excuse me. And the standard response mean, otherwise known as the efficiency index, is a second approach to effect size. And it's a ratio of the change from baseline to post-test divided by the standard deviation. The third is referred to as Guyet's responsiveness index, and it uses an anchor-based minimal clinically important difference, which we abbreviate as that MCID, of the smallest difference from baseline that is meaningful. So these are all things that you may see documenting validity of the measures, or particularly if you're reading about screening instruments or diagnostic instruments, you may see some of these terms and approaches described. And you may end up doing some of this work of your own in the future. And you may want to use some of these various approaches.